Okay, thanks very much for the invitation to speak today. And we're going to switch gears back to management of chronic heart failure, but for the adult population. These are my disclosures, some of which are relevant to the topics I'll be discussing in terms of medical and device therapies. So very brief learning objectives. I'm going to recap the definition of heart failure, which is not news to anyone, the impact of heart failure on healthcare in Canada, some examples of the disease trajectory, and then when we get into it, the bulk of it's going to be about current evidence-based management of heart failure and how we try and put it all together in the clinic. So heart failure, of course, is not new. This lovely picture is from 1694 with the severe ascites being treated by direct drainage, previously called dropsy, and has been described as far back as 1600 BC in ancient Egypt. So we've been living with heart failure for a long time. Multiple definitions out there. This is one of my favorites from Justin Ezekowitz, describing a complex clinical syndrome where abnormal heart function results in or increases the subsequent risks of clinical symptoms and signs of both reduced cardiac output and or pulmonary systemic congestion. Now, this is a slide loaned to me by Dr. Hawkins from Vancouver, but clearly demonstrating the impact of heart failure with a 50% mortality at 5 years. After hospitalization, the median survival is just over 2 years, 500,000 Canadians affected and 50,000 per year. And as people age, then it's about a 10% chance of living with heart failure. Again, the cost of heart failure is massive. And my colleague, Dr. Kabalnik, who you heard from earlier, spends a lot of time trying to avoid readmission for patients with heart failure with the rapid heart failure clinics, because over half of our costs in heart failure are from hospitalization. So this is really what we're trying to achieve in the clinic, is to try and reduce admissions and try and prevent readmissions. So there's a spectrum of heart failure, which of course you'll have heard before, but essentially you have 4 stages, and then you can also either go by stage of heart failure or the functional class and how the person's affected. So we range from high risk of developing heart failure but asymptomatic, to having some structural disease, but again asymptomatic. And then you're into stage C, which is symptomatic heart failure, which we class as class 2, class 3, or class 4 in terms of their symptom burden. And then stage D is refractory symptoms and very advanced disease. And of course, that's our trajectory. Now, historical heart failure treatments weren't great. Venesection used for a long time. And of course, of all the diseases treated with venesection, heart failure is one of the few that actually responded by reducing your circulating blood volume. And this poll was, of course, how the service was advertised. And we still see it outside barbershops today. And digoxin, that was all we really had. Venesection, and then we developed foxglove. So we had loop diuretics, initially metal-based diuretics, and then loop diuretics and digoxin. Now, in terms of eras of therapies, we then moved on to ACE inhibitors, angiotensin receptor blockers, beta blockers, mineralocorticoid receptor antagonists, or MRAs, and also hydralazine nitrate we've known about for a long time. More recently, we've had evidence to use Ivabradine, angiotensin neprilysin inhibitors, or sacubitril valsartan, and even more recently, SGLT2 inhibitors. So how do we pull all of this together? I'm not going to bore you with lots of Kaplan-Meier curves because usually there's far too many in talks, but essentially, here's an example of the SHIFT trial, which is 10 years ago now, showing us that Ivabradine reduced hospitalizations for heart failure. It didn't have a massive impact on mortality, but certainly improved morbidity. More recently, sacubitril valsartan, clearly beneficial compared to enalapril. And for SGLT2 inhibition, we've got DAPA-HF, and even more recently, you've had EMPEROR reduced, supporting SGLT2 inhibition in heart failure, both with and without diabetes. So our priorities of management in the clinic, particularly as people move from asymptomatic over to refractory disease, you're of course trying to improve symptoms all the time, and Dr. Balmain spoke a lot about diuretic management and how that will help with their symptoms and prevent readmissions. We're also trying to improve their survival by treating their underlying cardiomyopathy. So these are our guidelines from a few years ago. I'm going to briefly point out a couple of things here. Now, bearing in mind this is for heart failure with reduced ejection fraction less than 40%. So this is what we were guided to do about 3 years ago. The concept of triple therapy was introduced with an ACE inhibitor or ARB if intolerant, beta blocker, and MRA, like spironolactone, aldactone. Then you'd reassess symptoms. If they're asymptomatic, you continue and then reassess symptoms and ejection fraction. At this point, if they're still symptomatic, you could consider adding Ivabradine if their heart rate's above 70 in sinus rhythm, or you could switch their ACE inhibitor or ARB over to sacubitril valsartan. If they have more advanced or continue to have symptoms, but they have a heart rate less than 70 beats a minute in sinus rhythm, an atrial fibrillation, or they have a pacemaker, then they're not eligible for Ivabradine, but you could also consider the switch from ACE inhibitor ARB over to sacubitril valsartan. When you reassess the symptoms in LVEF, if the patient's doing well and the EF is recovering, you just continue. If they still have an ejection fraction less than 35%, you consider a device implant or referring for either an ICD or CRT, and I'll talk about that briefly. If there's of advanced symptoms, you can consider add-on therapies like hydralazine and nitrate. You can consider advanced therapies like mechanical circulatory support or transplant. And as was mentioned earlier, you can also consider palliative care. So that was 3 years ago. And essentially, for many years, this is what we've had in the clinic. So as you move from asymptomatic to refractory disease, then you'd basically work your way up the therapeutic ladder. You could start ACE inhibitors and then beta blockers and then aldosterone antagonists. Then you would decide on CRT or defibrillator and then advanced therapies. And of course, we now have ARNIs as an alternative to ACE inhibitors or ARBs. And throw into the mix that we now have SGLT2 inhibitors to consider, and then extras like Ivabradine, hydralazine nitrate, and probably in the near future, vericiguat for more advanced disease. In addition to the medical therapies, medications, and devices and advanced therapies, through the whole trajectory, you would usually discuss lifestyle changes such as fluid salt restriction, customized exercise training. Now, you see that was really a stepwise, we were always told about stepwise introduction of therapies and layering on of therapies, whereas now, really people are talking more about the 4 pillars of heart failure reduced ejection fraction management and really trying to target multiple pathways simultaneously with low doses and then titrating. So now the priority is really on angiotensin receptor and neprilysin inhibition over ACE inhibitors, ARBs, because of the proven additional benefit, beta blockers, MRAs, and SGLT2 inhibitors. And then there are others that you can consider in certain circumstances, such as Ivabradine, hydralazine isosorbide dinitrate, and vericiguat, as I mentioned. So this is a nice summary of how thinking is going by Drs. Lamb and Butler, just published this year. It was a nice review. Essentially, trying to think about it as 5 pathways: angiotensin 2, norepinephrine, aldosterone, neprilysin, SGLT. 4 drugs, the 4 pillars. And notice that ARNI is now the one that's bolded, and you may start with one of these, or you could start with the ARNI up front, depending on cost, availability concerns, kind of thing. But the emphasis is on the combined therapy here. Beta blockers, of course, MRAs, and SGLT2 inhibition, with 2 possibilities that have been proven to be beneficial in HFrEF. The others you can consider, as we mentioned, Ivabradine in sinus rhythm, heart rate above 70, hydralazine nitrate, particularly potent in self-identified blacks, and vericiguat for worsening heart failure for hospitalization reduction. In bold down here, you'll notice they've mentioned all attempts should be made to modulate all the pathways. So the idea of sequentially starting one or two medications, then reassessing, deciding how you're doing, and then considering starting something else, that's really falling out of favor, and you should really try and target as many pathways as you can as soon as you can and reevaluate quite quickly. So that's medical therapies. One of the reasons that we're trying to get people on good medical therapy and titrated medical therapy early is because if they don't respond, we want to consider a device. So we don't really want to be titrating medications for 6 months or 12 months. We want to try and get things done quite quickly and then reevaluate at 3 months and decide if they should be offered either a defibrillator or a CRT or biventricular device. And the reason is quite clear. Up to 40% of patients with HFrEF die suddenly due to arrhythmias. ICDs have been shown to improve survival. And we particularly use them if the EF is less than 30%, despite all medication titration and revascularizing, etc. You think you've done the best you can with other strategies. However, we don't tend to consider it in people who are of a very advanced disease or of a shorter life expectancy because they're unlikely to gain any mortality benefit. And just to highlight again that an ICD doesn't make anyone feel better or improve symptoms, it only improves mortality and Kaplan-Meier curve. So, and just to point out that this is particularly for ischemic cardiomyopathy, that those are the patients who get the best mortality benefit from defibrillators because they have a much higher risk of ventricular arrhythmia. How about CRT or biventricular pacing? So about 30% of our patients with HFrEF have conduction disease. Specifically, left bundle branch block can lead to inefficient LV contraction, and that's what we're targeting. So the ECG is very important for us when we're assessing our patients in clinic. And if left bundle branch block is present, then we can use CRT in addition to medical therapy if we haven't had the improvement in symptoms in LVEF that we need. And this is what it looks like very briefly. An atrial lead, the right ventricular lead, like a standard dual chamber pacemaker or defibrillator, and the left ventricular lead is threaded through the coronary sinus into the cardiac veins to target the lateral wall of the left ventricle. And this is what it looks like in fluoroscopy, with threading up through the coronary sinus and ending up with a lead up here at the left ventricle and the lateral wall. Now, the pre and post ECGs from left bundle branch block to using biventricular pacing, you can see there's a modest reduction in the QRS width. It doesn't seem very dramatic on the surface ECG, but the effect for patients is really quite dramatic. This is on the first studies from 2005 of the KHF study, showing the mortality and hospitalization reduction with the biventricular pacemaker. And this was not a defibrillator, so this benefit was all just from the CRT, biventricular pacing. Now, this is a slide that I adapted from Dr. Lam's slide and added some new things. And this is a kind of overview of what we're trying to deal with in the clinic and how I personally try and think about each medication or intervention as we work through it. So, of course, for all patients, you can consider a loop diuretic. We don't know about reductions in death. Dr. Kabalnik touched on how it can reduce hospitalizations, particularly if guided by invasive pressures. There's a cost in terms of blood pressure. Doesn't affect heart rate. Certainly can affect your EGFR renal function and reduces your potassium, and it's quite cheap. Lifestyle changes like sodium reduction, fluid reduction, regular exercise, certainly beneficial. We think it potentially could reduce death and hospitalization. Neutral effect on hemodynamics, renal function, potassium, and of course it's free. So really should be offered to everyone. Beta blockers have a very important impact on mortality reduction, hospitalization reduction. Some effect on blood pressure, significant effect on heart rate, of course, and do cost, modestly, lots of generic options. ACE inhibitors, although they were one of the first medications we had to impact mortality and heart failure, they actually don't have as dramatic an impact as beta blockers do. But certainly they reduce both death, hospitalization, do have an effect on blood pressure. No effect on heart rate, of course. Need to be careful with renal function. Can lead to potassium retention, modest cost. ARBs are equivalent across the board. ARNIs, sacubitril valsartan, as an even more impactful a bigger impact on death and hospitalization, significantly lowers blood pressure, neutral effect on heart rate, reduces eGFR, retains potassium, but costs a lot. MRA is also very impactful in reducing death and hospitalization, modest effect on blood pressure, no effect on heart rate, can affect renal function, as you know, and can retain potassium, probably more so than the ACE-ARB ARNI group, and are cheap. SGLT2 inhibition, again, very impactful, both death and hospitalization, but weirdly neutral in terms of blood pressure, heart rate, eGFR, may even be protective, as you know from several of the renal studies using SGLT2 inhibitors. No effect on potassium. At the moment, they're expensive, but otherwise, really very impactful in terms of what you get and what it costs you. The others that we add on, Ivabradine and sinus rhythm, not much of impact on death, but certainly reduces hospitalizations. Neutral effect on blood pressure. Now, this is important. This is something we face a lot, that we have patients who are struggling with hypotension, and we cannot titrate these other medications, but you could potentially add Ivabradine if their heart rate's above 70. The heart rate will reduce, of course. Neutral effect on renal function and potassium does have some cost implications. Digoxin, never proven to reduce death. It's a neutral effect, but seems to reduce hospitalization. And as Dr. Balmain mentioned, if you withdraw it, then people seem to do worse. Neutral effect on blood pressure. So again, you can consider it in people who are relatively hypotensive in the clinic. Have to be careful with their heart rate, of course, but otherwise quite a neutral effect on kidney function, potassium, and it's cheap. Hydralazine and nitrate, actually very impactful in self-identified Black patients in terms of reducing death and hospitalization. Has a significant effect on blood pressure, but otherwise really quite a neutral effect on renal function and potassium, and it's cheap. So it's the medication. So this is what we're trying to juggle. In other words, what's the patient in front of you? What are they facing? Are they relatively hypotensive? What's their renal function like? What can we work with, and what can we add? What can we titrate? Once you think you've done as much as you can with your medical therapies, then of course you're looking at whether they would be a candidate for a defibrillator or CRT. We know that they both reduce death. Hospitalization is reduced with CRT. And again, most other effects are neutral, but they're expensive. And advanced therapies, again, if all else fails, then you can consider advanced therapy. Now, the elephant in the room, I suppose, is that what about heart failure preserved ejection fraction? I've spoken pretty exclusively up to now about heart failure with reduced ejection fraction, with all of these options and difficulty choosing which one is best for which patient and when. But heart failure preserved ejection fraction accounts for about 40 to 50% of all of our heart failure patients with heart failure. So it's certainly something we see regularly and have to deal with all the time. Unfortunately, we've had multiple studies looking at medical therapy to improve outcomes in heart failure preserved ejection fraction. ACE inhibitors failed, ARBs also failed. MRAs may be helpful if you look at subgroup analysis. Beta blockers, possibly harmful if you look at meta-analyses. The study of high-dose nitrates in HFpEF was quite an ingenious study. They used movement trackers to see what people's activity levels were like, and actually it reduced people's activity levels significantly, so it's potentially harmful. Sildenafil used in this study was negative, and more recently we had Paragon HF with sacubitril valsartan that we were hopeful would be beneficial, but the overall trial was neutral, even if some subgroup analyses may have shown some benefit for selected patients. So we've had difficulty finding a therapy that can impact outcomes in HFpEF. So we're left with loop diuretics, potentially MRA for some patients, controlling blood pressure, controlling atrial fibrillation, treating ischemia, try and keep these people stable. I find for HFpEF, you need to watch renal function very closely. This is the balance we need to strike between diuretics and renal function. And all patients should, of course, have lifestyle advice about sodium and fluid restrictions, exercise, refer to cardiac rehab. Maybe we'll have other options in the pipeline. For example, there are ongoing trials recruiting, looking at SGLT2 inhibitors for HFpEF. So the summary, I find in clinic a lot of time is spent reacting to events. So, dealing with a recent hospitalization or a recent change, rather than trying to see the bigger picture. We need to try and, yes, react to events, but also try and look at the overall trajectory of your patient and when you should actually act. Inertia is the key. I think one thing we find in clinic is we actually have to capitalize on people feeling well and being quite stable to maximize their therapy. They're much more likely to tolerate titration of their medication if they're otherwise feeling quite well. I find I'm perhaps biased as a devices doctor, but I feel we should use devices liberally to improve outcome. And just to touch again on HFpEF, lifestyle education, monitoring renal function, I find are key factors. And there's always another therapy just around the corner. Thank you for your attention.